Okay, hopefully everyone is back. Enjoyed your lunch. We're ready to get back on it. All right, we'll take a quick roll call. Jig, are you back?
Yes.
Hi, Jig. Renee,
Hello, I'm back.
Jessie.
I am back.
Hi, Jessie, and Jason.
I'm here.
Thank you, Jason. Okay, next agenda item is 6, discussion and consideration of pharmacy-provided CLIA-waived tests, including potential expansion of authorized tests. As you may recall, the board sponsored SB 409 in 2021 to expand access to pharmacist-provided CLIA-waived tests. The legislation established the general types of tests that pharmacists could provide under specified conditions, but left open the potential for additional expansion of authority. I included this item on the agenda for open discussion to determine if at this time, if the interest of public safety, the board should consider expanding pharmacists authorized tests. Members, unless you have any immediate thoughts, I recommend that we open up for public comment. Any thoughts on that first? So, moderator, if we can open up for public comment on this agenda item.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you're logged in and would like to participate, click the question mark inside of the square, type comment, send it to all panelists. If you're calling in, *3 to raise your hand from your phone, virtually from your phone. At this time, I have no requests. Would you like me to close the Q&A?
Yes, please. Maybe there's one person popped up, Elizabeth.
Yes,
If you
popped
wanna.
Thank you. Lucas Evanson, I'm going to send a request to unmute your microphone. Just a friendly reminder, I'll set my timer to 3 minutes. Lucas, you're unmuted.
Can you hear me?
Yes.
Oh, okay. Thank you. Sorry about that. Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA believes further work needs to be done to implement the existing list of tests before additional tests are added via regulation. Importantly, we want to ensure patients are being referred appropriately to their primary care provider for treatment and further assessment. So we thank you for providing this opportunity for public comment.
For the comments.
This is the moderator. Stephen Gray, I'm going to send a request to unmute your microphone. Just a moment as I locate. There you go. Request has been sent.
Thank you. At this time, I don't have any additional tests, specific tests to recommend. However, there have been some progress or in other states. And I would suggest that it would be good to reach out to the other states and get a list of what they have under this category for their pharmacists. I'm thinking specifically of probably Idaho, Washington, and several other states to reach out to. Reason you need to start doing that and perhaps start doing it regularly is because, as you can tell from the legislation, it's a regulatory process. There does have to be input from the medical board and the laboratory folks. And so you really want to stay ahead of this if you can, so that the California pharmacists are doing as much for the residents of California that they can do as compared to what other pharmacists can do in other states. It's very important to get ahead of it. That's my recommendation. Thank you.
Thank you for the comment, Dr. Gray.
The moderator, Mark Johnson, I'm going to send a request to unmute your microphone. Request has been sent.
Hello, Mark Johnston with CVS Health. I wanted to clarify that the overwhelming majority of the states allow pharmacists to process CLIA waive tests in accordance with federal law. A CLIA waive test is a test that's so simple that a 13-year-old can use it. The overwhelming majority of the tests are available OTC, and very few states actually have a list of what tests can be used. Most states are silent and therefore defer to the feds and just plain allow every federally allowed test that a 13-year-old can use to be performed by a pharmacist. Um, California, in stepping in and over-regulating in this area, is hampering pharmacists and is further regulating beyond the federal responsibilities. So if you do go to Idaho and Washington, you're not going to find lists. There are a few states that do have lists. Of course, my suggestion would be to eliminate this list and just allow pharmacists to perform every CLIA waive test that is federally allowed. If we were to add to the list, pregnancy tests are CLIA waive tests, so a pharmacist can't even help a woman with a pregnancy test. I would suggest adding women's health to the list. Thank you very much.
Thank you for the comments, Mark.
Moderator, next individual, Richard Dang. I'm going to send a request to unmute your microphone.
On behalf of the California Pharmacists Association, we are in support of any action the board might take to further expand the tests that are able to be done that are CLIA waived. I do agree with previous comments. There are well over 125 individual CLIA waived tests. I don't think the board would like to go through the process of evaluating each one. So if there is an opportunity to promulgate further regulation to keep it broad, as the previous public comment made, I would likely encourage that. The good news is the current list of conditions is quite broad and does encompass a wide variety of tests that are available. However, as new ones come about, we don't want to spend the time to have to look at each individual one. Yeah, but overall, we are in support of continuing to evaluate if we can add on more to allow more pharmacists to perform these CLIA waive tests.
Thank you for the comments, Dr. Dang.
This is the moderator. No additional requests. Would you like me to close the Q&A?
Yes, please. Thank you, Elizabeth. Yeah, I think the intent of me bringing this up is just more expansion of the pharmacist allowed tests that can be performed by pharmacists, not to be overly prescriptive, not to be overly broad. I just wanted to get members' thoughts on getting this process rolling as a regulatory path. The authority is somewhat given us a little bit of power, and I think this may be a good opportunity for us to start the discussion on getting this rolling. With that, Jesse, your hand is raised.
Thank you, Sung. I think this discussion is good to have continuously. Also, just of course noting that there was a proposed bill earlier this year that did fail to go through that would expand some of the CLIA waive tests. And now that we have AB 1286 and AB 317 that have been signed into law and will go into effect, I'm curious to see how that will play out and if we do see more tests being performed in pharmacies because they'll actually get reimbursed for them, and see kind of how this plays out in terms of staffing to allow for these tests to be performed. So I think it's a good discussion to be had, but I think we should look out to see how these other laws impact the number of tests that are being performed in pharmacies.
Thank you, Jesse. And with AB 317, if it's implemented correctly, I think this is a huge opportunity for pharmacies to really kind of revolutionize and provide better patient care. As part of LGBTQ community myself here, I would love to be able to go to a pharmacy to get tests and more tests. I mean, granted, yes, I hope there is a treatment component, of course, but I also understand the realities of the realistic what we can do legally and all that stuff. So Jake, your hand is raised.
Now, I'm totally for this. Access is one of the key factors, and getting tested on time is super important. And I think the list can grow from here on, but we are taking the right step here, and it's going in the right direction. I'm really happy about it.
Thank you, Jake. Okay, any other member comments? I think that from this discussion, what we can do is to have Anne reach out to medical board and other necessary. Oh, go ahead, Renee.
I just, yeah, wanted to also make the comment about like the others, just that, it'd really be in support of, expanding the usage of the CLIA-waived tests. I mean, when you look at the list, the FDA list, I mean, it's huge. And if that's an opportunity for the public to have easy access to a test that helps them with the decision point about their health, then I'm all for it. But yeah, there's definitely some other steps in between. So, but I'd be supportive, a little less prescriptive and a little more just allowing, but I know that there's other steps in between. So,
Yep. Sounds good. Okay. So we'll work with staff on what may be the next steps from our discussion today. Just want to get this going, get the members' thoughts. Next item is the discussion and consideration of central fill pharmacies. All right. Members, strategic objective 1.2 calls for the committee and the board to consider and pursue necessary changes in the law regarding various pharmacy practice settings to ensure variances in the practice are appropriate. Consistent with this strategic objective, I have scheduled this discussion on central fill pharmacies, as well as discussion of mail order pharmacies under the next agenda item. As we begin, I would like to confirm that members received the written comments received related to this agenda item. And note that to aid in our discussion, there are a number of policy questions included in the meeting materials. Similar to the process used related to pharmacy technician ratio, I intend to discuss each question among members and then open up the discussion to the public. So we'll get started on it. Question 1, should labeling requirements be updated to ensure patient-centered labeling requirements are satisfied? Should the label include names of both pharmacies? I think patient-centered labeling requirements apply to all prescriptions dispensed to California patients. So the patient-centered labeling requirements already apply, but maybe to ensure licenses have a clear understanding of the requirements, maybe we can update to the regulation language if this area is appropriate. Members, your thoughts? I'm jumping right in. So if anyone have any broader comments, please feel free to make it as well about central fill pharmacy. Jesse?
Yeah, I agree with your interpretation, Sung. Just reading this, it seems like the patient-centered labeling is already a requirement. So I think it's a little redundant to clarify any further than it already exists.
All right. Any other thoughts on question 1? I know this is an easier question. Renee?
I I kind of wanted to ask a question about, because I'm not familiar, but the other part of the question was, should the names of both pharmacies be included?
Mm-hmm.
So I'm thinking, I mean, just for clarification, so currently that is not the case.
No, I don't believe the current regulation related to central fill pharmacies is very, very, I would say, not as clear, kind of broad in some way. It's 1707.4. That really is kind of the central fill pharmacy regulation. So maybe we could require that there shall be 2 licenses where the prescription is filled and then where the prescription is going to be picked up. So
I guess I wouldn't necessarily, I think that warrants a discussion. I think that could be confusing to the public.
Mm-hmm.
So I think there would need to be some discussion. I was just trying to clarify because I think that could be confusing, but I certainly think that someone should know where their medications are coming from, possibly. So, in the background, knowing that. Not sure how
Okay.
that best way to inform.
Got it. Okay. So there may be some more questions coming up later that we could discuss this. Okay. Jesse, is your hand raised for this?
Yeah, just following up on that. So it looks, and I just want to make sure I'm understanding this correctly, that it can either be the central fill pharmacy that's address is on it, or the pharmacy in which the patient is picking up. Is that how I'm interpreting it correctly? Is that right? Just one or the other?
In the current regulation under 1707.4A, and I think it's and or. So yeah, I think it's one or the other.
Got it. Okay. Thank you.
Any other thoughts on this? Okay, we'll go to public comment.
This is the moderator. The Q&A is now open. The instructions will be on your screen here shortly. If you would like to participate, click on the question mark inside the square, type comment, send it to all panelists. If you're logged in, if you're calling in from your phone, press *3 to raise your virtual hand. So at this time, I am going to call on, I sent a request to unmute your microphone.
Hi, Richard Dang on behalf of the California Pharmacists Association. I'll start with my general comment and then maybe address the policy item you presented, Chair O. So yeah, I think as we saw in the materials and in discussion with many of our members, central fill operations is something that's been happening for a long time in California that has previously been supported by the Board of Pharmacy. So, I as a general practice, I believe that it is something that is allowable in our current practice through the regulations and laws that we have. I think what's being requested generally is just a clarification and a re-endorsement by the current makeup of the board and staff that is something that is continued to be allowable, because there are several companies and members who are thinking about opening a central fill but are hesitant because they're not clear on whether it's explicitly allowed or not, even though it has been happening for a long period of time over the last few decades. And as this conversation gets discussed as well, I used to work at Kaiser, and so I'm familiar that there is a central fill operation, a very large one with that. So, I would encourage, if we need any information about operations and errors, that we engage with that stakeholder to learn more, as they are probably, in my opinion, the largest operator of central fill operations in the state. Probably in addition to that, some PBMs and potentially some of the chain pharmacies as well. With regard to the policy item on prescription labels, I agree that my understanding is that it applies to all prescriptions filled, so I don't think it needs to be clarified some more. When it comes to the second pharmacy, my understanding is that most companies that run a central fill are operating under the same entity. So it wouldn't necessarily be two pharmacy names that are on there. It would be Kaiser operating a Kaiser central fill, which is separate from their main pharmacy that the patient's visiting. So I don't know if having two pharmacies on there is entirely necessary. But the understanding is that the address of one of those facilities is included on the label, and I think it is open for the company to decide which one to place onto there. Thank you.
Thank you for the comments, Dr. Dang.
This is the moderator. The next individual, Sarah Poyo-Mu. I will send a request to unmute your microphone, and I'll set the timer for 3 minutes.
Thank you. Can you hear me?
Yes.
Hi, I'm Sarah Poyo-Mu with the California Community Pharmacy Coalition. I too am going to start with a general comment and then comment on the policy item on the prescription labels. The California Community Pharmacy Coalition is happy the board is having this discussion and supportive of the current practice of central fill in California. We urge the board to maintain its existing broad interpretation of central fill and technology-assisted final verification services in California. Specifically, we support the authorization for a pharmacy to process both a request for refills of prescriptions received by a different pharmacy and new prescriptions. We also believe that pharmacies should continue to be able to utilize automated verification technology, and that final verification at a dispensing pharmacist should not be required, as this takes away much of the usefulness of central fill. And on the labeling policy item, I would like to state that labeling requirements should only include pertinent information for the customer to appropriately take their medications, as to not cause unnecessary confusion. There is already a lot of information on labels, and requiring additional information would be burdensome and distract from other important disclosures on prescription drug labels. Thank you.
Thank you for the comments.
Next individual identified as Nick Mesa. Nick, I'm going to send a request to unmute your microphone.
Good afternoon, board members. Nick Mesa with Quarles and Brady. I'll speak just specifically to this question here, and then I have a broader, more detailed comment as we progress down the line. I've had the benefit of supporting a number of pharmacies engaged in central fill or shared services operations across the country. And we see a number of variations among states, but there are also a number of states that have just common requirements as a whole. So with respect to the labeling piece, I'll echo what Dr. Dang said. I'll echo as well the prior speaker. It is certainly a very common practice among pharmacies, whether they are engaged in a central fill arrangement with commonly owned entities or non-commonly owned entities, to include the pharmacy information of the information of the pharmacy that filled the prescription, or a unique identifier. Those are common requirements in multiple states, and so as the board looks to engage in a position on this particular issue, the one thing I would flag is that as these central fill and shared services models become more and more common and more complex, there are oftentimes some 2, 3, or 4 pharmacies that might be involved in the processing of the prescription, not just obviously a single one being involved in the fulfillment. So as the board kind of looks at this issue, ultimately what matters is that the patient can identify that there is a central fill or shared services arrangement at hand, and that he or she may be able to contact the necessary personnel to answer questions regarding that script. And that I think is already covered by the existing rules in the state. So I'll reserve the remainder of my comments for the other items. Thank you.
Thank you for the comments, Nick.
And the next individual identified as John Gray. John, I'm going to send a request to unmute your microphone. Request has been sent.
Thank you. Good afternoon. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. I'll speak mostly to the questions at hand on this item about labeling. But before I do that, just thank you to the committee for taking up this topic. We think it's timely. We think it's important. As the meeting packet noted, it's been a couple of decades since this regulation has been contemplated, so the time is probably right to do that, and we're happy to participate in that discussion. I do want to correct the record a little bit. Some of our practices have changed since Dr. Dang has been at Kaiser, and so we may not have as much contemporary knowledge of central fill practices as he represented, but we do think we have some interesting thoughts to share about it. So on the labeling piece, Dr. O is correct. 1707.4 A to B specifies that the label must show either the name and address of the pharmacy that refilled the prescription and or the name and address of the pharmacy that received the refilled prescription for dispensing back to the patient. We think that requirement actually works okay and don't recommend changing it, except for potentially adding a provision that the pharmacy's practice, how the pharmacies are going to label the prescription ought to be specified either in policy and procedure or a contract, so that if the board were to investigate an issue, there wouldn't be question about which pharmacy's name should be on the label. You could point to a policy and procedure or contract to substantiate that. And then secondly, on the question about the patient-centered labeling requirements, we have no concerns about requiring that centrally filled prescriptions comply with the patient-centered labeling requirements. And I think maybe the reason for this question is kind of much of the meat of the patient-centered labeling requirements sit outside of Business and Professions Code 4076, which is what's referenced in the refill pharmacy regulation currently. Thanks very much for the opportunity to provide comment.
Thank you for the comments, Dr. Gray.
This is the moderator. Next individual, Stephen Gray. I'm going to send a request to unmute your microphone.
Thank you. Thank you again. This is a super important topic. Central fill has proven to be a great improvement in the reduction of dispensing errors. It's a great improvement in reducing the chaos at local pharmacies that may have interfered and caused errors, where there's been a lot of discussion about. And it's also improved the ability of pharmacists to be involved in a richer and a better way with total health care. Let me state two things. First of all, I was the project leader for Kaiser Permanente's first central fill, which was the first private central fill in the United States. Way back in 1995, filled our first central fill prescription that actually went to a patient on August the 1st, 1996. We did studies on every aspect of central fill, including measuring the error rate, measuring the local staff satisfaction, measuring patient satisfaction, and measuring the impact on things like prescription counseling. So I would really encourage you to, before you do anything on this, to make sure you fully understand that. And I will give as much as I can in my allotted time, but please do not hesitate to ask questions. Central fill, first of all, there's some missing information from your background material. The legal basis for central fill was actually current regulation 17, hang on here a minute, I got to go to it. The regulation that allows for delivering a filled prescription to any licensed pharmacy in California. I believe that's 1713. That regulation has existed since at least 1976, was actually put in place because it was starting to be common practice for depoting filled prescriptions at food stores, gas stations, and other things at the request of patients. That regulation explicitly allows, ever since then, to depot a filled prescription at a licensed pharmacy in California. Later, after the Kaiser pharmacy was operational, the regulation was adopted, partly from the things we learned. The issue of the address was, a study was done on that. And as was mentioned, it was confusing to patients if you tried to put both on there. And so that was why the regulation allows it. I also want to mention that there is a central fill DEA regulation that also allows either address. I do support the patient-centered label and believe that ought to be enforced. Current regulation, current law under the new bill 1286 will require reporting of all errors. I do think that ought to go forward also. Thank you. I believe my time is about up.
Thank you, Dr. Gray. I believe there will be ample time as we address all the other questions for you to help us with your expertise and history and all that has in the past with this regulation. Thank you. Don't see any other comments, Elizabeth?
No additional comments. Would you like me to close the Q&A feature?
Yes, please. Thank you so much. Okay, with that, We're gonna go for next question. Question 2, given the number of errors reported from Central Fill Pharmacy, should the regulation require final product review at the dispensing pharmacy before the prescription is released to the patient? This is gonna be, I'm sure, a lot of somewhat controversial, so I'm sure we'll have a lot of thoughts. So as noted in the meeting materials, the board has received some QA reports from Central Fill Pharmacies documenting medication errors. Given that under the existing law, both pharmacies are responsible for ensuring the order has been properly filled, it appears that the law already envisions some sort of final product review or verification. I'm not sure how that works in practice. I would feel more comfortable requiring some form of final verification, either via picture or some technology, not maybe at the dispensing pharmacy, but at least at the final product verification level. So efficiency and innovation are good, but there are limitations that as we consider consumer protection, I think there are limited, just to me, there are minimum requirement that we should be seeking for that would ensure that the medication that's going out to the patient, that final product is verified by a pharmacist that one time. But that's my thoughts. Members, I see Jake raise hand, and then I'll go to Jesse.
Thank you, Sung. Do we have like data, like how many errors, like compared to the general trend, average errors that happens at that prescription volume, like 5 per 100, 2 per 100 filled, something like that?
I'm not sure. I'll defer that to our lovely executive officer for that, but we may be able to gather more information on that topic as our law 1286 is finally here, and we may be able to finally have an idea of that. So I see what you're going though, Jake. I mean, I think that for the volume, the error rate is could be questionable, and I don't know. I don't have an answer for that.
Yeah, and I think again, I personally don't have much experience with Central Fill Pharmacy, but I would think that there's a lot of automation involved, a lot of robots that are there that are counting the medications, etc. So, I mean, technology versus human error, right? That's one thing. But overall, my feeling is, I mean, this thing is working. There were some studies done based on what Dr. Stephen Gray mentioned, and I think we should just leave it as is.
I think so. Great point, Jake. I also agree that it's not working or it's working. I'm not really. I think the reason why this is being brought up is to provide clarity, not because it's not working or it's working. There was some comments that was brought up that seek to clarify what was clearly allowed and what was clearly not allowed. And so that's the idea. I am not here to try to say Central feels bad or it's great. I think there's absolutely, benefits. I think what we're seeking here is clarity. And, due to the regulation being so old, I think there's an opportunity for clarity. So that's what, this is brought up. This is not in any way to try to jeopardize Central Fill or to attack or to make Central Fill everywhere or promote Central Fill. Not at all. This is just kind of trying to figure out if there's an opportunity to provide clarity. Jesse?
I think, Sung. I've mentioned this at quite a few meetings that I generally believe that the final product verification should be able to be accessible by a pharmacist who can physically open the bottle and take a look inside. I can't tell you how many times we've caught errors of tablets that look almost identical the size, the color, and maybe the imprint is a little different, or you have a couple of tablets that were placed incorrectly. So I worry about leaving this technology completely out of the hands for pharmacists. Alternatively, I like the idea, Sung, that you're proposing of being able to capture photos and having the dispensing pharmacist be able to access those so that they can actually see the product before dispensing it. It's kind of like when you think of brown bagging, when you get the medication. I mean, you're able to see the medication, but if you're just dispensing it to the patient, maybe a little different. But overall, relying 100% on technology is something that makes me a little uneasy. Particularly, I mean, we probably have to dissect this further, and I'm sure the Enforcement and Compounding Committee already did this, but it's kind of something we probably fully don't have the answer on, but whether the automated drug systems attributed to an increase in the number of errors, we don't really know, of course, because there was and isn't currently mandatory med error reporting. Hopefully we'll get some clarity on that as time goes on. But I wouldn't be opposed to actually requiring either pharmacist, it doesn't have to be the dispensing one or the central fill, to actually physically confirm that the medication being dispensed is correct before packaging it.
Thank you, Jesse. Any other thoughts before we open up for public comment? Renee?
I just want to make a comment. I mean, this is the one question that kind of addresses kind of specifically like the safety for the public in terms of, central fill and the handoff between central fill and a dispensing pharmacy. So I would think that the dispensing pharmacy should have some clarity on what they're handing to a patient. So like Jesse's saying, I mean, you just open it and take a look, or you are able to click into images. So, again, I know that is probably, if it's not being done, then it's, going to add a workload. But I do feel like if there are errors, then there needs to be some secondary check, physical check. Even though there's all the technology available, we kind of know that there's human points of error in a lot of technologies, even though there's barcode scanning, et cetera. So I think it's an interesting question, but I think it would depend also a little bit on getting some more clarity on exactly how many errors, which we don't really know because of the error reporting.
Yep.
So
absolutely agree. Thank you, Renee. Okay, any other thoughts? We're gonna open up for public. I knew this question was gonna be tricky, so this is I think the rest is not gonna be as tricky. So hopefully we'll breeze by. All right, Elizabeth.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you would like to participate, click that question mark, type comment, send it to all panelists. If you're calling in, press *3 from your phone to raise your virtual hand. And we will start with Nick Mesa.
Hi again, thank you, Board. Nick Mesa with Quarles and Brady on behalf of multiple stakeholders, licensees in the state, utilizing not only central fill models, but technology assisted verification. So as we noted in the board materials, we are just truly trying to seek confirmation that the board ultimately still defers to the professional judgment of pharmacists when utilizing technology for prescription verifications within pharmacies. Now, the board has, as we noted in our materials, provided express guidance on this. Again, it was more than 15 years ago, in January and October of 2005, in the board's formal newsletter, The Script. And in that letter, they specifically noted that the board, it stated that it is the pharmacist's responsibility to ensure 100% accuracy of a dispensed prescription. Critically, the board noted that if a licensee seeks to utilize technology for such verification, they may do so pursuant to their professional judgment and at their own risk. So again, as the use of technology and automation becomes more common in the industry, Really, stakeholders are just seeking confirmation that the board still holds the position that the use of this technology is permitted and is ultimately at the discretion of the pharmacist. I also want to clarify, some of the comments that may have been made, or at least the conclusions that are being drawn with respect to this type of technology. I don't think we'll ever get to a point where humans are not involved in verifying the product that is placed in these automated systems. I think really ultimately some of the questions that were posed in our letter really focus on whether final human verification at the end of the process of fulfillment is required. And it's really critical to highlight the technology that is utilized in these closed automation systems, utilizing canisters where the fulfillment of those canisters prior to the fill of a prescription is 100% verified by a pharmacist before it is placed in the system for fulfillment. So again, a pharmacist is involved in that verification. It just doesn't happen at the end of the line, so to speak. And then one final comment, I'll note just generally that, the manner in which this question has been framed, I think makes some erroneous and unsupported assumptions regarding errors in central fill pharmacies. I think, and we would be happy to provide this to the board, there are multiple peer-reviewed articles that demonstrate the use of automation and these types of technologies dramatically reduces filling errors when compared to standard human fulfillment of prescriptions. And again, we're not talking about ADDS systems here. We're talking about central fill models and the use of automation within those models to fill scripts prior to the dispense. So again, looking forward to hearing the board's discussion on this. And again,
Sorry about that. The 3 minutes were up. I muted the line. The next individual, Nicole Cover, I'm going to send a request to unmute your microphone.
Good afternoon. Can you hear me?
Yes.
Okay, sorry. Nicole Cover. I obviously have spoken a couple different times. I'm actually from Michigan, covering for one of my colleagues today, Lori Walmsley. It's her birthday. So wanted to just let you guys know a couple of things around micro-fulfillment. When I looked at it as a board member in Michigan and the states that I have it currently operating, I think one of the things is, like Jessica, to your point earlier, like the physically open the bottle. I think the biggest thing that I've always said as a board member is I'm not just going to make assumptions based on what things are being thrown out or how something's being presented, but going and actually looking at the automation and seeing the facility and watching it go. We have had a lot of deans and local leaders, local board members, executive directors think one way, and then they come and actually see it and say, oh, well, that answers a lot of questions, because an automated dispensing device is a counting device, and you will have errors with quantity, which I noticed that you guys are referencing an error as incorrect quantity, which is statistically different than completely wrong drug or wrong product. I'm a pharmacist and I do still cover shifts, the bench. If I look at the top of the bottle, I have no idea if there's the wrong pills in the bottom of the bottle. If I look at a bottle physically, I don't know if there's 60 in there or 51, right? Like, I think that we have to look at what we're doing. What is the end game? We talk about workplace conditions and we talk about needing to relieve, but then we want to make things difficult or jump through loops of fire when we have alternative sources. So I wholeheartedly will give any of you an invitation to look at any facility. There's several facilities that are all different automation companies, Kroger, Walgreens, Kaiser, the people that have mentioned today. But if you haven't seen a central fill micro-fulfillment facility, I think it's really hard for you to talk about errors if you haven't seen it and don't understand, because a counting device is not a fully robotic automation. The canister can't be filled with the wrong product, a lookalike product, the wrong tablet. None of that can happen. All of that has been reviewed and looked at. And so I think the other 28 states that are looking at this, just don't let California fall behind or look at certain numbers and make assumptions. I just encourage you to look at it and actually physically get to the facility so that you can make a better understanding. And I think you'll realize that it's a really good thing for the public health and safety. Thank you for your time today.
Thank you for your time.
Next individual, Rob Dixon, I'm going to send a request to unmute your microphone. And just, again, this is a moderator, just double checking, legal counsel, Crowley, your hand is up. Did you have a question?
I don't have a question, thank you.
Rob Dixon, your microphone should be unmuted.
Can you hear me okay?
Yes.
Hi, my name is Rob Dixon. I actually represent a company called Innovation Associates. We're the technology solutions provider behind a lot of the central field facilities in the country. Also, interestingly enough, I'm a former regulator from the state of Illinois. And we've reviewed this issue when I was there with the board as well. One thing I would just caution against when we frame this conversation in relation to errors, as my colleagues previously mentioned, there are a lot of peer-reviewed studies, including from the Institute for Safe Medication Practices, the National Association of Boards of Pharmacy, the American Pharmacy Association as well, that kind of highlight the benefits of automation and the reduction errors that occur versus what traditionally occurs in the dispensing process now. In addition, the sentiments that were raised about workplace conditions is really the crux of what we inform our products and solutions with. And I do welcome an opportunity to sit down with the board and walk through our technology solutions, as there are a lot of safety features that are built in, and a lot of that has been informed by regulatory practices throughout the various states. And so the most we can do to avoid errors or misfills or whatever, what have you, we've built that into our technology practices. And then just one final request I would have is to be able to see the data that's informing your policy decision or conversation right now related to errors, because I'd be happy to have a broader conversation on that as well. But overall, I just want to thank you all for the opportunity. And I look forward to future discussions on this topic. We would be really happy because to me, Central Phil is about healthcare equity and access. And so we want to make sure Californians in the right position and ensure that all Californians are getting the access to prescriptions and medications that they deserve. Thank you.
Thank you for the comment.
The moderator, before we call on the next individual, I want to correct myself, and that was board member Crowley, not legal counsel. I just wanted to correct myself there. I apologize. Next individual, Jassy Grewal, I'm going to send a request to unmute your microphone.
I think she said she no longer needs to make a comment on the following comment.
Thank you. Next individual, John Gray, I'm going to send a request to unmute your microphone. Request has been sent.
Thank you. Good afternoon again. This is John Gray, registered pharmacist with Kaiser Permanente. Just a few points we want to make on this item, and many of them are echoing the comments of Quarles and some of the things that they brought up in their letter as well. First, we do just want to express that the framing of this question does seem kind of unfortunate in that it begins with saying, given the number of reported errors reported from central fill pharmacies, but the board hasn't shared any data with the regulated public about the number of errors reported from central fill pharmacies. And unfortunately, this is a not uncommon occurrence where we see the board framing its discussion in this manner, using anecdotes to stand in for data. And so we would encourage the board, recognizing that some of these errors may be still working through the disciplinary process, we would encourage the board to share what data it has, so that we're all we all have access to the same information when we talk about this. But more directly to the question at hand, we absolutely support Quarles' recommendation that the board reaffirm its position that it stated in the two 2005 issues of the Script newsletter. The underlying law supporting the board's stated position in those issues of the script hasn't changed. And so I guess I'm a little skeptical about why the analysis would have changed. And, even more broadly than that, the regulated public views the script as a trusted source of the board's policy on various matters. And so, we would like to expect that if the board's position on something as important as this had changed in the intervening time, it would tell the regulated public, because these issues of the script are still available on the board's website and still appear to represent the board's policy. And then lastly, getting to the specific question of should a regulation require final product review at the dispensing pharmacy before the prescription is released to the patient, I could see issues with that if the central fill arrangement is one in which the central fill pharmacy performs the fill and then sends it back to the dispensing pharmacy. The dispensing pharmacy wouldn't have an electronic workflow available to do another product verification. So I'm not really sure what that would look like.
I apologize, I muted the line. The 3 minutes were up. The next individual I
Dr.
did.
Gray.
Thank you. Sorry, I'll try to make sure to pause in between for the thank you and then moving on to the next individual. Sorry, Chairperson.
No worries.
Stephen Gray, I'm going to send a request to unmute your microphone.
Thank you again. Getting right to the issue of errors. Again, in 1995, we worked months and months on being sure that we were ready and testing and testing. Kaiser Permanente, as many of you know, is a totally integrated care organization. That means it has all the information, it has all the data. For the most part, all Kaiser Permanente members have to get their prescriptions filled and refilled at Kaiser Permanente pharmacies. This was a Southern California project. So what I'm going to speak to, Northern California had not embarked on this at that time. We promised the Board of Pharmacy, there was an inspection by Chief Inspector Ken Sane, and later when it was in operation, the Board Executive Officer and several other board members did visit, and I would highly encourage that. Technology has changed since then, and it's only gotten better. We tested, we knew exactly what the error rate was for our pharmacists. We first dealt with refill prescriptions. There was always the intent to do also new prescriptions and mail order with that technology. The average pharmacist in an 8-hour day at a Kaiser pharmacy, which is different than others at that time, in a year filled 40,000 prescriptions. That's about 120,000 prescriptions, 120 prescriptions a day. In 40,000 prescriptions, the average pharmacist made 3 errors. 3 in 40,000. We promised to keep track of the errors made from the refill pharmacy. Again, it was refill at that time. After 6 months, we reported to the board that it was 1 in 4 million. 1 in 4 million. We kept that going for another couple of years, and it only got better as the technology was improved and as people were held accountable for the human things that they did. Remember, a central fill pharmacy is not just counting pills. It's not just counting capsules put in a vial. There are tubes of ointment, eye drops, cough syrups, other things that a pharmacy technician has to put a label on. So you can't think of only pills in a bottle. The other thing, again, to keep in mind that I don't think that final look in the bottle at the local pharmacy is actually even a good idea. As was mentioned, they don't have the technology, and this can only be done between 2 pharmacies that have been held mutually responsible for the accuracy. And now with the new law about reporting errors, I would encourage you. The Board of Pharmacy actually at one time said that at our central fill pharmacy, we did not have to have a pharmacist look in the bottle because they wanted to encourage all California pharmacies to move to this or towards this as a error reduction standard. And that's what they would hold us responsible for. Again, thank you for opportunity to comment.
Thank you for the comments, Dr. Gray.
Next individual identified as Keith Yoshisuka. I'm going to send a request.
Keith Yoshizuka, California Society of Health System Pharmacist. I don't quite have the depth of experience as Steve Gray. I was employed by a small company called Kaiser Permanente um, back in the 90s, and we started in Northern California. We started about a year later. So there's been about 25, almost 30 years experience with the central fill as the beneficiary um, of a pharmacy manager. It reduced the workload and improved our ability to counsel by having more time at the local pharmacy. And as the previous speaker had suggested, I highly encourage um, members of the board, if you haven't already seen it, to arrange for a tour of a central fill facility. I've gone through several times, at least at the Northern California Central Fill, and the sophistication and the speed at which the prescriptions are processed, and every single prescription, was reviewed and approved by a pharmacist before the cap went on the vial. It is automated as well, and it goes to a camera, and the camera looks down into the vial. It is a digital image of what it's supposed to look like, and everything is barcoded. And until you see it, is hard to understand. But once you go, once you visit the facility, it's easier to understand how the error reduction can occur. If you have the opportunity, I really, really recommend a visit to a central fill facility. Thank you.
Thank you for the comments, Dr. Yoshizuka.
Requests? Would you like me to close the Q&A?
Yes, please. Thank you. All right. Thank you, everyone, for your comments here. And moving on to the next question, unless members have any thoughts.
Dr. O, I think we need to go for a tour.
Ah, yes. I think that would be a good idea. It's pretty cool facilities out there.
Yeah, it seems interesting.
Question 3, should the regulation be amended to clarify that central fill pharmacy may dispense both new and refill prescriptions for a pharmacy under contract or under the same ownership? I believe the language as currently written could be interpreted in 2 ways, but it is important to clarify its policy on this issue and to update the language accordingly to ensure the regulated public has a clear understanding of the board's requirements. So I think this one, pretty easy. I would say that it should be open for both, clearly say that it's okay for new and refill prescriptions. And I think that's how the business has been practicing for a long time already. Jesse, your thoughts?
I agree. I think the language is a bit unclear, and it is the practice that it's both new and refill. So I think could probably afford some clarification just to be as clear as possible.
Thank you, Jake.
So I understand right now the current practice, both new and refill prescriptions are being filled at the central fill pharmacies. If we do one or the other, let's say, think about, change the language to just refill. What benefits are the consumer get out of it? I mean, it seems like having the whole concept of central fill pharmacy, it helps the workload at the local pharmacy level so they can focus on patient-oriented, much fulfilling tasks, spending longer time at counseling and other clinical practices. So I, I don't know. I mean, I'm just trying to get my head around this. Like, why? I feel like we're trying to reinvent the wheel here, where things are working just great.
I'm not trying to reinvent the wheel, Jake. I was just, this is just clarifying what was considered a little unclear. So I think that's where, yeah. So I agree. No, I completely agree with you. Jason?
Thanks, Sung. I think I just do want to join in with Jig here in seeing, do we have data? Happy to clarify questions, if there are indeed questions out there that industry has. But, you know, is there a problem? Is there data? And I think that would be helpful helpful to me before continuing on with the conversation.
Got it. Absolutely. Okay, with that, we'll open up for public discussion. Moderator?
This is the moderator opening up right now. The Q&A is now open. Instructions are on the screen for your reference. If you would like to participate, click the question mark inside the square, type comment, and send it to all panelists. That's if you're logged in. If you're calling in, press *3 from your phone to raise your virtual hand. We're going to start with John Gray. John, I'm going to send a request to mute your microphone.
Right, thank you. John Gray, registered pharmacist with Kaiser Permanente. We're supportive of the board clarifying that the regulation allows central fill for both new and refill prescriptions via whatever mechanism it thinks it needs to do that. If the board thinks that the regulation as it's currently written is sufficiently broad that allows that, I think, you know, saying it in the script or board minutes or a policy statement should suffice. And then again, just to be crystal clear, and with all due respect to my predecessors at Kaiser Permanente, I want to be very clear that today, Kaiser Permanente likely is not or is not engaging in the practice of central fill pharmacy as we're discussing it today at the scale that that some former Kaiser Permanente employees are representing. So it's an important issue to us, but and their experience and feedback, I think, is important to the board's discussion. But I want to be really clear that practices have changed, and it's not we're not engaging in the practice of central fill pharmacy to the extent that we may have in the past. But thanks for the opportunity to provide comment.
Thank you, Dr. Gray.
This is the moderator. Next individual, Keith Yoshizuka. I just sent the request to unmute your microphone.
Thank you, Keith Yoshizuka. I posed a question, you know, to differentiate new versus refill. I've been taking my medication for you know, a long time as, you know, treatment of my diabetes and hypertension. And of course, it's not going to go away anytime soon, but there's a limitation as to how much data storage is. So periodically, a new prescription number will be assigned as more refills are added. So technically, when a new prescription number is assigned, that's a new prescription, even though nothing has changed. Even in cases where I go to see my provider, says, okay, we need to adjust your dosage. And in that case, I still have been receiving my my prescriptions. I get it by mail order, which is the next topic. But you know, that gets sent out to me, and I get a notification actually right on the prescription label. It says directions have been changed, and I get a note saying, if you have questions, please call the 800 number for consultation. So I'm strongly recommending that you know, it be viewed as both new and refill, and primarily for the benefit of the public, because we're talking about continuity of care. So I get all my prescriptions mailed to me. So, you know, I wouldn't appreciate having to go into a local pharmacy just because 2 years has passed and a new prescription number has been assigned. Or I visited my doctor and he says, okay, we're going to change your dose. Okay, I can't get that from by mail order because new prescriptions have been written. I would prefer to receive it the way I'm used to receiving it now. Thank you very much.
Thank you for the comments.
This is the moderator. Now moving on to Stephen Gray. I'm going to send a request.
Thank you again. I want to go back to what I first said. The legal basis for central fill pharmacy is not in 1707.4. It's in 1713, a version of which has existed at least back to 1976. Back then it was regulation 1717C. There was a numbering of all the statutes and regulations sometime in between, but the wording is the same. And that regulation says that a pharmacy can depot or send to another licensed pharmacy a filled prescription for pickup by the patient. And that's what central fill is all about. And and actually, because that regulation existed, the last subsection of 17704, which is subsection B as in boy, was added at the suggestion of legal counsel for the Board of Pharmacy, so there wouldn't be any confusion that the pharmacy called a refill pharmacy in the title could fill new prescriptions. And that section reads, nothing in this section shall be construed as barring a pharmacy from also filling new prescriptions presented by a patient or a patient's agent or transmitted to it by a prescriber. So I do not believe there is anti-ambiguity. I believe that from a legal interpretation point of view, counsel probably is familiar with the concept of the negative pregnant. And because it wasn't mentioned in this regulation, board counsel at that time recommended that subsection be added. And again, it's a practice of sending prescription from one licensed pharmacy to another for pickup by a patient. And that still occurs even from non-central fill pharmacies. There are medical centers that have 3 or 4 pharmacies, and when 4 of them close at 5 o'clock or 6 o'clock, they send their new prescriptions down to the pharmacy that's open all night, so that patients that can't get there before 5 or 6 o'clock can pick up their new prescriptions. And that was referred to in the old days as depoting, but it is still allowed explicitly by regulation 1713. Thank you.
Thank you, Dr. Gray.
I have a next individual identified as Nick Mesa. I'm going to send a request to unmute your microphone.
Thank you, board. Again, I'll keep this very short and sweet. As the board knows, over the past decade, pharmacies in the state have been operating on the guidance of the board that pharmacies may fill new prescriptions on behalf of another pharmacy. We're requesting that the board again confirm that position, simply because as pharmacies within the state begin to implement central fill shared services operations, that 2016 guidance has become somewhat stale, but we do certainly agree with the previous commenters in that we understand that the board's prior confirmation of the ability of a central fill pharmacy to fill a new script was really based on a reading of multiple provisions, not only 1713, but of course 1707.4 and indeed 1717.1, which notes that the use of a common electronic file to allow for the processing of prescriptions among multiple pharmacies. So again, we encourage the board, or we're simply requesting and respectfully requesting clarification and confirmation that it maintains the same interpretation and enforcement posture that it has had over the past decade on the ability for pharmacies to fill new scripts. Thank you.
Thank you for your comments.
This is the moderator. No further requests. Would you like me to close the Q&A?
Yes, please. Thank you. All right, moving on to next question. Question 4, should a patient provide consent or receive notification that the prescription will be filled at a different pharmacy? I do think that this would be a good idea. I do get a little nervous about, in practice, may get a little messy. So, I mean, I think in general, this would be a good idea. I think patients should be in the driver's seat, but also situations come up that is dynamic work of getting a prescription filled. People change their minds. I just get a little nervous about making so strict or so restrictive. So with that, your thoughts, Jesse, if your hand is raised?
Yeah, honestly, I think this would be really confusing for patients. My patients already get confused with just refill reminder text messages, thinking that their medications are ready. And so I see this being a huge mess and could potentially be a barrier for patients to get their medication in a timely fashion. I hear what you're saying, and I think patients should be in the driver's seat and should have some ability for decision making. But ultimately, I fear that this could potentially delay a patient getting a medication they need.
Thank you, Jesse. Renee?
Yeah, I kind of echo Jesse's comment about just confusion for the patient, because, using the terminology like to provide consent, somebody may not quite understand and think they have to go somewhere else. And, anyways, just I think an awareness, I wouldn't even go as far as an acknowledgement, but just an understanding that their medications are maybe not being filled on site, but will be provided to them at the site. Something like that, just so that they are informed. But yeah, otherwise, I think just asking them if it's okay or not is not gonna serve them well, really, in the end.
Sounds good. Thank you, Renee. Any other thoughts? Ready for public comment?
This is the moderator. The Q&A is now open. The instructions are on the screen. Click the question mark, type comment, send it to all panelists. If you're logged in, if you're calling in, *3 to raise your hand. Individual identified as Nick Mesa, I'm going to send a request to unmute your microphone.
Thank you again, board members. Just a quick comment on this piece, and would agree with the comments of the board members. Again, in reviewing and seeing a number of these models across all 50 states, I will note that it is exceptionally rare, if not, I think, entirely rare, for a state to require prior consent to engage in a central fill or shared services operation from the patient. What is, however, most common among states is that the patient be provided some form of notice that their prescription may be filled by another licensed pharmacy. That notice may be in the form of a one-time written notice, or in the case of a traditional kind of central fill model, with the postage of signage within a retail model. So again, just providing that background to the board, and we would agree that the requirement of a prior consent to engage in this would not serve the benefit of the patient. Thank you.
Thank you for the comments.
Individual, Rob Dixon, I'm going to send a request to unmute your microphone.
Thank you. I really will just echo the sentiments that Nick just raised. Most states that do require some type of notification, most of it's usually signage with the dispensing pharmacy. And so that's been pretty sufficient, and it works well in a lot of states across the country. So just if the board is considering this, that's one avenue you can take to ensure that patients are aware that their prescriptions are being filled off-site. Thank you.
Thank you.
No additional requests. Would you like me to close the Q&A?
Yes, please. Thank you, Elizabeth. All right, we're plowing through question 5. Should we limit central fill pharmacies to only operating within California? This is a difficult question again, but I'm concerned that we currently do not have a good means for assessing non-resident pharmacies for compliance with California law. Given that, I'm inclined to limit to central fill pharmacies to only located inside of California. I recognize that it's going to be challenging, so maybe there's a way to grandfather any central fill pharmacies that are located outside of California, but establishing some mechanism for inspections maybe is a possibility. But appreciate your thoughts on this.
So we currently have central fill pharmacies outside of California, licensed by California board?
I will defer that to Angie because, don't want to say anything incorrect. That's my understanding. There's some facilities that may be serving pharmacies in California that maybe is outside, but I'll defer to Anne. Or maybe we have public comment who could actually answer those questions for us.
Yeah, I think I would just say, maybe we defer to public comment. We know that there's a number of non-resident pharmacies, but we don't typically differentiate in our licensing scheme.
Jesse?
Sorry, I'm a bit confused by this question too. If a central fill pharmacy is outside of California, would it not be a non-resident pharmacy?
Oh, I think the question is, would we allow a non-resident pharmacies to perform a central fill pharmacy function for a pharmacy in the California versus would they have to be located inside of California, not a non-resident pharmacy?
Okay. Not a non-resident. Okay. It's a little confusing for me to think of. I'm still processing what exactly that means.
Basically, would the facility have to be in California or is outside okay?
Okay. I mean, as long as they're licensed, take for example, mail order. I think that if I'm understanding this correctly, the difference for mail order is you're going directly to the patient versus central fill pharmacy that would be going to the actual pharmacy itself. Is that right?
Right.
As long as they have a non-resident license, I mean, I don't think there is much difference, to be completely honest.
Okay. And Renee?
So just for clarity again, so there are non-resident central fill pharmacies, non-Californian central fill pharmacies, but
I will not be able to answer that for you for sure.
Okay.
It's but I think it's a question.
Yeah.
Should we limit it or should we not?
Okay, yeah, I mean, I would not be of the opinion to limit it. However, I would think that just like we do with our non-resident compounding facilities, they're licensed and get inspected and hold to the same standards. So if that's already happening, yay, and if not, that's what I would recommend.
Yeah, I think the question was brought up because to hold those standard is a challenge.
Yes.
So that's why the question was brought up, is to holding non-resident to the standard of resident pharmacies has been challenging. That's been which we are discussing on next agenda item as well. So that was the thing. Jake?
I just wanted to state that I agree with Renee that the way we handle non-resident compounding, the same way non-resident central fill pharmacies can be handled as well. And given you're stating that it's difficult to get out of state and the cost and all of that, so I understand those factors.
All right, thanks, Jake. Jesse, did you have another comment or? Oh, okay.
No.
All right, we're ready for public comment on this question.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you would like to participate, click that question mark, type comment, send it to all panelists. Or if you're calling in, press *3 from your phone to raise your hand. So I'm setting up my timer here, and first individual, Nick Mesa, I'm going to send a request to unmute your microphone.
Thank you, members of the board. I'd love to provide some background here as perhaps why this question may have been posed. Within the section 1707.4, again, addressing refill pharmacies, and we certainly heard from Dr. Gray related to kind of the history of central fill operations. Under A, there's verbiage that notes that a pharmacy licensed by the board may process a request for a refill of the prescription received by, quote, a pharmacy within this state. I think traditionally what has happened over the past decade or so, folks have understood, or at least within the industry, have believed that this refill pharmacy rule governs central fill. And that unique verbiage there, while we don't necessarily agree with this interpretation, was meant to limit central fill activities to only permit them among resident pharmacies. And so there's been ambiguity over the past decade relative to whether cross-state central fill models were permitted. And a classic example would be there's, for example, a central fill pharmacy in Arizona that might fill a prescription for a retail pharmacy in California. Or to one of the board members' earlier comments, if it's dispensing directly to the patient, it would generally be operating under the mail order rules of California. So again, that's kind of the backdrop there. We agree that the verbiage of the rule would seemingly permit cross-state arrangements, but I think it's just a matter of finding clarification from the board and that those cross-state arrangements are permissible because, again, the pharmacies involved would absolutely need to be licensed by the California Board of Pharmacy. Thank you.
Thank you for the comments.
Identified as Keith Yoshizuka, I'm going to send a request to mute your microphone.
Thank you very much. I'm wondering if the question might be answered in Business and Professions Code 41112 regarding non-resident pharmacy. And it starts off, any pharmacy located outside the state that ships, mails, or delivers in any manner controlled substances, dangerous drugs, or dangerous devices that should be considered a non-resident pharmacy, so on and so forth. So wouldn't a central fill pharmacy located outside of California still be considered a non-resident pharmacy? Yeah, that's my point. Thank you.
Thank you for the comments, Dr. Yoshizuka. Elizabeth? You're muted, I think.
Thank you. Next individual, Stephen Gray. I just sent a request to mute your microphone.
Thank you very much. Yeah, to give a little, again, background on this, back in the 80s, quite frankly, there was a trend for some manufacturers to limit the distribution of their drugs to only certain pharmacies, and not all retail pharmacies, if you can use that word, or community pharmacies could actually get those drugs either from the wholesaler or from the manufacturer. And so the regulation that was pertinent, again, was current 1713 or old 1717C, where those out-of-state pharmacies that were on the list of pharmacies that could get those drugs were allowed to ship filled prescriptions for a patient that they had registered, which was a requirement of their REMS, which is a REMS medication evaluation system required by the FDA, to a pharmacy for that patient to pick up. And it was a good deal because it also meant that that pharmacy they shipped it to had a chance to put those prescriptions into the patient profile and therefore evaluate them as part of the whole patient's medication regimen. So I do believe that there's not a problem. A pharmacy licensed outside the state has to follow California rules. So I don't think it's necessary to have a separate category. Again, if there needs to be a statement in a Q&A by the board that clarifies this, that would probably be very valuable. But I don't think it's something that needs to be changed at this time substantively, because it's been happening on a depoting basis since at least the 80s, when Sandoz, for an example, restricted patients to only going to their contract pharmacies for Clozaril. Thank you.
Thank you, Dr. Gray.
Next individual, John Gray. I'm going to send a request to mute your microphone.
Thank you, John Gray, registered pharmacist with Kaiser Permanente. We're also supportive of the position that this practice should be allowed for pharmacies outside of California, central filling by pharmacies outside of California. But again, by whatever mechanism the board thinks is necessary to tell the regulated public that. And I think that's my comment on this. Thank you very much for the opportunity to comment.
Thank you, Dr. Gray.
This is the moderator. No additional requests. Would you like me to close the Q&A?
Yes, please. Thank you, Elizabeth.
Yeah.
Okay, with that, next question is 6. Should the board define central fill pharmacy? Oh, this is tricky, but some developing a definition would be clear, but what comes with that also is a question, right? So I am open for opinions and thoughts on this, members. Jesse?
Yeah, I'm a little torn on this too. I think we already have specific regulation for central fill pharmacy, but the question then becomes how it evolves over time if creating a specific definition is going to limit the functions of the central fill, and so I'm kind of on the fence about that one.
Yeah. Okay. And any other thoughts, Jake?
I think we should just leave it as is.
All right. Sounds good. And with that, we're going to open for public comments.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you'd like to participate, click that question mark, type comment, send it to all panelists, or if you're calling in, press *3 from your phone to raise your hand. First individual, Stephen Gray. I'm going to send a request to mute your microphone. And I'm going to set the timer to 3 minutes.
Thank you very much. I do not believe it needs to be redefined or defined in either statute or regulation. However, we've always been told, and I believe that it is true, that the title to regulation is not law. And I do believe it would help clarify the situation if 1707.4 were not labeled as a refill pharmacy, because we now know it speaks to both refills and new prescriptions. So possibly in the next iteration of the law book, it could be just an administrative change to change the title of that regulation. Thank you.
Thank you, Dr. Gray.
Next individual identified as John Gray. I'm going to send a request to mute your microphone.
John Gray, registered pharmacist with Kaiser Permanente. We agree with Steve. Don't think there's any need to define the term central fill pharmacy, particularly if the board moves forward with making some of the what sounds like it could be administrative clarifications that have been discussed. Then the pertinent regs seem to kind of appropriately define the boundaries of what can and can't be done. And then the definition, a formal definition, doesn't seem necessary. Thank you.
Thank you, Dr. Gray.
Moderator, no further requests. Would you like me to close the Q&A feature?
Yes, please. Thank you, Elizabeth. Last question. Should the regulation for central fill pharmacists be limited to non-controlled medications only? I note that comment in the meeting materials regarding DEA limitations on transferring controlled substances, but that also is a question if that is applicable here or not. I think the question is a bit tricky, but I think at least staff can reach out to the DEA for clarification on their position on this topic. But I personally think that there should be no limitation, but just open for your thoughts. Jay?
Yeah, Dr. O, I think there should be no limitation because there are regulations specific for central fill pharmacy that the DEA has for them. And they would have to comply to that. So,
Okay. Sounds good. Jesse, is your hand raised? What? Oh, go ahead. Yeah.
I actually do think that we should limit it to non-controlled substances. Just in terms of liability for controlled substances and the PIC at the dispensing pharmacy, being able to make that decision on what products and what controlled substances are being dispensed from their pharmacy, I think is really important to PIC autonomy as well. Yeah, I'll just leave my comments at that.
Okay. Understandable. Totally understandable. All right. Any other comments? Okay, we're opening for public comment. Since it's the last question, I'm going to open for public comment and just, I think it's okay. It's just any global comments that anyone would like to provide, please feel free to do so for all the public comments in attendance. Regarding this agenda item, question 7, but also any global, but I will just in case if there's anyone run out of time, I will open for another public comment so you can finish your thoughts. But question 7 and any other global comments for any public comments, please feel free to chime in. Elizabeth?
The moderator, the Q&A is open. The instructions are on the screen. If you would like to participate, click that question mark, type comment, send it to all panelists. If you're calling in, *3 from your phone to raise your virtual hand. I'm going to go in order here. John Gray, I'm going to send a request to unmute your microphone. John Gray, request has been sent.
Thank you. This is John Gray, registered pharmacist with Kaiser Permanente. The only global comment I have is thank you for the really productive discussion on this topic. I think I got in, essentially all the targeted and global comments I wanted to in other items. But again, thank you. I think it was productive, and I'm excited to see kind of the work product that the board lands on based on the discussion. On the question of should the regulation be limited to non-controlled medications only, we would echo Board Member Patel's comment that DEA has very clear regulations addressing central fill pharmacy for controlled substances, and pharmacies would obviously be expected to meet those if they decide to engage in central fill for controlled substances. So we don't think that that the California board needs to implement anything above and beyond or different from DEA's requirements. Thank you very much for the opportunity to provide comment.
Thank you, Dr. Gray.
Stephen Gray. And Stephen, I sent a request to unmute your microphone.
Thank you again. I also would like to congratulate the president and the group for really allowing a lot of good comment and background information and taking the time and effort to fully get into this. I also, by the way, just as a general comment, I want to make sure everybody realizes that John Gray and Steve Gray are not related. We both work at Kaiser Permanente. I'm retired from Kaiser Permanente, but I would hate for my reputation to have an adverse effect on him or anything of that nature. Having said that, I want to give a reference. DEA regulation 1306.15 is one of the places where the DEA has regulations on central fill. And that regulation starts out by talking about Schedule II controlled substances that are clearly allowed in the DEA regulation, and as well as other schedules of controlled substances. But it's important to think of what this may mean. There are pharmacies in California that for a variety of reasons have, and obviously it's Schedule II, so we're not talking about refills. There are a variety of pharmacies in California that have decided not to carry certain Schedule II items, maybe any Schedule II items. And so this provides an alternative for a patient to have a prescription filled at a central fill pharmacy and have it delivered to that local pharmacy where the information, again, can be incorporated into their profile, and they can get the full service of drug interaction checking, et cetera, and yet not incur the liability or the security issues or whatever it was that they felt made them not carry any Schedule II items. And also, there are continuing therapies for schedule controlled substances, certainly Schedules 3, 4, and 5, but some of those are very serious medications that the patient needs to take on a regular basis, and this facilitates compliance. So I would encourage the board to not limit central fill to non-controlled substances. Thank you.
Thank you for the comments, Dr. Gray.
This is the moderator, Rob Dixon. I'm going to send a request to unmute your microphone.
Oh, again, thank you for putting this conversation together. My name is Rob Dixon. I'm the Legislative Affairs Director for Innovation Associates. And as the leading technology solutions provider in this space for central fill pharmacies and automation, I just want to reiterate some of my colleagues' earlier comments and really encourage the board to engage with the stakeholders and licensees and really visit some of these central fill facilities. Again, I'll also offer myself as a resource. Being a former regulator, I understand some of the issues you're up against and working through. So I would be happy to at least talk through IA's technology and the solutions we've built and how they work and how they are geared towards patient safety. And again, I just want to thank you guys for having this conversation and look forward to engaging with you in the future. Thank you.
Thank you for the comments.
Moderator, no further requests. Would you like me to close the Q&A?
Thank you, Elizabeth. Appreciate it. All right, with that, I think we are gonna take a quick break, but unless members are okay going forward, because I think next discussion is not gonna take that long. And then before we go to next agenda, I just want to open up for one opportunity for members to comment and just to see where we go. I think that it may be clearer for us to update the regulation. I don't know if FAQ is going to be sufficient or strong enough, so I'm kind of curious where you all are on this. Or is FAQ you think is sufficient for these? Are the questions that came up today? Are we able to provide that clear guidance based on just our policy statement and the legal interpretation, or should we update that regulation? I'm leaning toward updating regulation. I know it's a long work, but I think that would just make it more clear, and that we can kind of start updating that from today's discussion and bring it back to the committee for the next meeting, if that's agreeable. Any strong thoughts, one or the other?
So I think that nothing needs to be updated, in my opinion. I mean, things seems to be going well. I mean, I don't see any issues that's causing any public harm or anything like that, and it's been buttoned up pretty good.
I think our stakeholders are asking for clarification though, so I would like to give them some clear guidelines. So that's where I'm hoping for us to be able to provide. Where are we? So that's,
Sean, this is
yeah.
Jesse. I agree. I think we do need some clarification. I don't feel strongly one way or the other if we should do so via updating the regulation or just having something clear in the script. I think either would suffice and I would be okay with either.
Okay. Renee?
Yeah, I would agree that there definitely needs to be some clarity. I'm not sure that I feel strongly either way how it's communicated out, but I think pulling this all together as a sort of an updated review, since it has been so long, and I think there's various regulations that support this, and it would at least be good to like consolidate as a review that this is how this is supported, through the regulations. So
And go ahead. Yeah.
If the committee is comfortable, unfortunately, our regulation council was unable to attend today. I think there's pros and cons to, the policy statement or an FAQ versus the regs. Generally, we want our regulations to be as clear as possible, so that you can avoid, these kinds of, where to avoid potential conflicts or different interpretations. So if the committee is agreeable to just allowing us to just kind of check in with our reg council as well, maybe before the committee decides exactly which path it's going to choose, just so that we at least you have that information before you. Thank you.
Okay, sounds good. If it's agreeable, based on our discussion, we can bring up maybe a regulatory proposal for next meeting or continue this discussion for next meeting. So, and we'll see where we can go with updating this. Hopefully not too significantly, but go ahead, Jason.
Yeah, that would work for me, Sung. I also would like to data on, where are these problems, and in the future, maybe not before we start this discussion, a tour of these facilities. I really would find that interesting also. And unfortunately, I have to step off now. Thank
Okay.
you.
Thank you, Jason, for staying on all day long today. It's been a long meeting. Appreciate it. Thank you for your comments. Bye, Jason. Don't leave everyone else though, because we still have one more thing to talk about. So, okay, sounds good. We're gonna move on to next agenda item 8. We'll just plow through this. Like our last discussion, I'd like to receive some feedback from members on the board's current regulation of mail order pharmacies. As I shared during our discussion under the last agenda item, I'm concerned about the board's inability to regulate non-resident pharmacies, including mail order pharmacies. I agree with the comments in the meeting materials that mail order pharmacies create unique challenges for patients. I can recall at least one investigation that resulted in discipline stemming from these challenges that are placing patients at risk. So I believe there are opportunities to improve our oversight of mail order pharmacies, and our consideration of this issue could extend to several meetings depending on our discussion today. So, and before I open this up for discussion, I want to note that I believe mail order pharmacies may have a place. They definitely have a great place in patient care, but I am extremely concerned about what appears to be a transition away from direct pharmacist-patient interaction, which is really contrary to the policy direction of the board. Also, reminder, I think we have a legislative proposal to require PIC to be a California licensed pharmacist in non-resident pharmacies, which we'll try to find the legislature next year. Or maybe this could be a sunset issue as well. So with that, members, just want to gather your thoughts. If there's any ideas, I think I mentioned during the committee, in the meeting materials, there was a discussion of, you know, if the board could have certain regulations for mail order pharmacies to follow, such as temperature tracking, or any other, you know, defining that if you are considered a mail order where you know, we could define it. If you mail 75% of your prescription, you would be considered a mail order pharmacy and you would have to follow certain rules and regulations. This is just talking out loud, thinking out loud. So just wanting to get your thoughts on it. Jesse, your hand is raised. Sorry, go ahead.
Thank you. Do we have a definition of mail order pharmacy currently anywhere in statute or regulation?
I don't believe so. And Corinne, can you please confirm?
This is Corinne. No, I don't believe that there is. I mean, there's code provisions that talk about, you know, internet pharmacies, but there's no definition of mail order pharmacy.
Okay. I think my feelings on the subject probably pertain to all non-resident pharmacies, whether they're mail order or central fill. I think there should be a good standard for patients, and it should be up to standard. Hopefully we get somewhere with the PIC being California licensed. The other thing too that I'm curious about, I thought I remember seeing that there was the restriction on travel to certain states in California has been lifted, if I remember seeing correctly. Maybe Anne or Corinne can provide us more insight. I'm curious to see if that means that it will be easier to enforce non-resident license, and if they could provide some insight on that.
Sorry about that. So, Jesse, I'm hoping that I'm understanding your questions and where I'm missing the mark. Just feel free to like bring me back in. But in general terms, yes, as I understand it, the legislation that prohibited, you know, the state from traveling to certain locations has been lifted. Where I think that there is a bit of a challenge potentially is, unlike our non-resident sterile compounding program, where there's explicit statutory authority and requirement for the board to go to those jurisdictions, right, and to perform those inspections, and there's a cost associated with that, and our fee schedule recognizes that cost and specifically calls it out. We don't necessarily have that same kind of statutory structure for non-resident pharmacies, right? It's just kind of limited to just the sterile. So if that's something that, you know, the board, and we've kind of danced around the discussion previously, we're happy to have some internal discussions, you know, and maybe talk to, you know, some of the different control agencies to see how we could best effectuate doing some of those kinds of things. We would need a little bit of policy direction from the board. You know, you'd want us to go annually or, you know, quarter, like whatever that would be. And then we can probably like try to figure out what that implementation path would be. I hope that I at least kind of hit what you were trying to get me to speak about.
Yes, that's exactly what I was thinking. Thank you. The other thing too, I know that some other states have at least had requirements like temperature tracking. I absolutely think that's something that needs to be considered and needs to be implemented in our state as well. Particularly in California, we have extreme temperatures here. We have heat waves all the time across the state. And of course, there's parts of the states too where it snows. And so I think requiring temperature tracking moving forward is something that we really need to seriously consider.
Thank you, Jesse. I think that, you know, you just got to be mindful. I think most non-resident pharmacies, you know, they're filling, I mean, millions and millions of prescriptions, right? So they're huge impact. I think that they should be prioritized in inspecting that they are doing the right job. And so I would like to propose that we have some sort of, discussion. Maybe this could be a sunset discussion, but at least I would propose that, we can consider adding some sort of an inspection requirements, not annually, I think it's not possible, but maybe at least every 4 years, at least every 2 years. We can try to see if we can get the proposal, you know, through. So that may be something we can discuss. Jake, go ahead.
No, I totally agree with you. I think if they are shipping into California, inspection should be done. And, if that's not in there, then should be implemented. Going to, one of the factors that Jesse brought up, I think, yes, temperature control is important. Stability of thousands of medication depend on those windows, etc. My only concern is, I mean, every prescription medication that's received and over the counter in every pharmacy, hospital, or whatever setting it is, I mean, it comes so many different paths. So should we be taking a holistic approach to the entire supply chain and products coming to each of our retail pharmacy in California, and whether they're being transported and shipped in these temperature guidelines per manufacturer? I mean, the issue is not just mail order. I mean,
No,
the way I'm looking at it, it's every way it's coming. And should we look at it at a broader angle and look at all of it separately?
Great point, Jake. Yeah, I mean, yeah, you're right. Absolutely. Jesse?
Yeah, I hear you. I think that that is something to consider. Just thinking of receiving medication though from my wholesaler, it's going from a truck that is at least a decently controlled temperature. Of course, it can fluctuate, but it's being handed directly to a pharmacy versus with a mail order pharmacy. They could drop it off at a patient's house, drop it on their porch, put it in their mailbox, whatever it is, and then who knows how long it's waiting there before the patient actually gets it, versus a handoff from one person to the other. And yeah, that's something I think worth a bigger discussion probably.
Yeah, I mean, obviously DSCSA has the whole pedigree requirement that's been, going on for 10 years plus. But yeah, I mean, it's a concern, right? And there are so many ways. And when you look at it, the reason I said we have to take holistic approach, because think about just regular delivery of prescription, which many pharmacies does, right? Just same day delivery, and is it dropped off at the porch and things of that nature. So, or even just within state prescriptions delivered to individual homes, or even white bagging, all of that. I mean, it's like a plethora of different network how prescriptions move from until it's consumed by the consumer. So it's pretty complex.
Oh, yes. The white bagging is definitely a concern. I wish we could do something about that, Jake, no doubt. Renee?
Yeah, maintaining the quality of the drug, through, extreme temperature fluctuations, is a quality issue and definitely should be addressed. But yeah, it's already in a brief discussion, you can see that it's like, expansive. So definitely worth a discussion. But I just wanted to also add that I do think that the mail order pharmacies should have some type of inspection again, for California patients safety wise. And we know how conditions can get sometimes in any pharmacy. So just wanted to make that comment.
I think that's a great issue I think we may be able to bring this issue as a sunset issue, is my suggestion. Because I know changing that would be an Herculean task, and we already we're very tired, I feel like, to somehow passing AB 1286. So I think sunset is coming up fast, so maybe this can be wrapped into a sunset issue. Um, just a side comment, like, I know that mail order prescriptions has like certain requirements for consultation that I myself, I know they're not really being followed. Those certain minutes that, they must be able to speak to a pharmacist. I have been on hold with mail order pharmacists when I know, I'm not, they don't know I'm not a patient, but yet I'm on hold for much longer than what is minimum hold time that is defined in our regulations. So I think there's definitely opportunities for us to kind of, um, protect California consumers because, mail orders are a huge contribution to, how people getting their medication, which I totally support. There's definitely a place for it. I just wish that we could make sure that they're done so patients can get a hold of these pharmacists and pharmacy staff. Um, Many times, every time you talk to mail order pharmacies, I mean, I know this is anecdotal, but I think that I've spoken to enough mail order pharmacies that this is pretty standard experience I've experienced is that I had challenges getting a hold of a pharmacist to just talk to about simple stuff. I mean, minimum, I mean, always on hold for 15 minutes, 30 minutes, 40 minutes just to get a prescription transfers. So there's a lot of opportunities I think we could discuss about this topic, and any suggestions on how we should proceed it would be very appreciated here today as we wrap this discussion up. So any thoughts on should we try to wrap this into sunset issue? Is there anything that we could do? Should we update patient consultation regulation on that section? Or should we try to define mail order pharmacies? Go ahead, Jake.
So, when you say wrap it into sunset issue, can you clarify that? I'm not
Oh,
100%
sure.
clear
Yeah.
with
So
that.
our board, Ann can probably speak better on this. I'm not gonna, I think I talked all day, so I'm gonna let Ann speak on the sunset process as the our sunset date is approaching faster than we think. So Ann, take it away. You're muted though. Still muted, Ann.
So the microphone that I had is lost its battery. So I apologize if there's a feedback loop.
Oh. Oh well, I'll just speak on the sunset really quick. So sunset, as you know, is how the Board of Pharmacy is essentially around. It's sunrise is so when sunset time approaches, which is January 1st of 2026, we provide a very comprehensive report about the state of the board and the issues that are surrounding. I think Ann, is your mic back? Because I wanna. Okay, go ahead, Ann.
Yeah, okay. I don't know if this is gonna work. If I see, oh my goodness. Okay, can you hear me still?
Yeah, this is fine.
Okay.
Go ahead. Go
All
ahead.
right. So I think that the sunset review process, I'm sorry, there's a lot of feedback in this room.
Just give me a pause for a minute.
It's okay.
Number 8.
It's okay. Sorry. So anyway, I'll just do my best to explain. So as you've seen from the last sunset report, we have extensive list of questions that the board has looked at. And rather than trying to have an individual piecemeal legislation support, sunset is a very holistic approach of what's going on in the pharmacy, Board of Pharmacy regulated area, on how we could improve consumer protection via certain topics and how we regulate. So, you know, so just to give projection of the timeline, sunset date is January 1st of 2026. The legislator has to approve and look at this issue in 2025. So we would really have to have the report done by, I would say, late to middle, like we would have to have draft report by the end of 2024. So it's coming faster than I mean, oh my God, 2023 is almost over. So it's coming faster. So that's why I'm as the discussion of many other issues come up, I think that I'm going to continuously possibly refer to that wrapping into sunset issue. So I apologize for not setting that
Yeah.
context into that.
Yeah, because I mean, this is a wide issue of supply chain and distribution. It's so, I mean, if that's what you think that would be the right way to go, then, sure.
And are you back on? How are we doing up there in Sacramento? And you're still muted though. Cannot hear you.
Okay, can you hear me now?
There you go. Yes.
Okay, we apologize. Well, I
The
apologize
board
for the
office
audio
is
issues
working
here.
overtime today. Yay.
Yeah, so Sunset really does create a unique opportunity for the board to identify issues of concern and then really work through the legislative process and with legislators on what that appropriate solution should be. So as part of the Sunset Report, in addition to responding to all of the previous issues, the board has the opportunity to bring forward new issues where it is identifying and offering recommendations to the legislature in more of a comprehensive fashion. And so I think that what President O is suggesting is that the regulation of mail order, or specifically, I'm not quite sure where you all are going, either the regulation of mail order or separately or as part of securing maybe more direct authority and statutory mandate to conduct inspections of non-resident pharmacies. So right now you have it for you have it specifically for non-resident sterols and outsourcers, and then there's also a provision for some non-resident wholesalers that are not VADA accredited. So there's another area where you can, but absent those specific examples, there is no statutory recognition of the need to do that. And so Sunset may be a good vehicle with which the board could have those discussions and work with legislators to address the problem that you all have identified.
Gotcha. So, okay. So it's just not the temperature control, it's just the whole thing.
No. Temperature control would be one of the many discussions that we may have in the future. Yeah.
Okay. Thank you.
And I'm also, I mean, temperature control is a great idea, but I think I would not be okay also requiring that for some small independent pharmacies or anything, that to me, I think would be a little unreasonable, but it's a great idea that, just an example. Anyway, Jesse, your hand is raised. Do you have a thought on there?
Yeah, I think having something more comprehensive is definitely beneficial. I think having a more robust discussion, kind of like what we did today, and kind of breaking it down and what the issues we want to address in terms of non-resident licenses as a whole, I think is really important.
Yep.
And I think that the timeline will work out for basically 2024, having that be a big focus on it as we continue the discussion.
Sounds good. Okay, so with that, I think this is any other comments? I think I'm going to open up for public comment and then we're ready to move on. So, moderator?
This is the moderator. The Q&A is now turned on. The instructions are on the screen. If you would like to participate and you're logged in, click on the question mark inside of the square, type comment, send it to all panelists. Or if you called in, press *3 from your phone to raise your virtual hand. So we will start with Sarah Polomu. I'm going to send a request to unmute your microphone, and I'll set my timer to 3 minutes.
Okay, great. Thank you. Thank you again to the committee for collecting and considering all of the public feedback provided here today. Sarah Polomu again with the California Community Pharmacy Coalition. Mail order is a critical service to patients. Without it, there would be a significant reduction in access, and this would be exacerbated by the current pharmacy closures we're seeing across California. Requiring temperature monitors in all packages would be problematic to implement and incredibly costly, and there is no proof that there is a need for this. It is also important to take into consideration the entire supply chain and look at this issue holistically, not just the pharmacy, but the entire supply chain and distribution of drugs before they land at the pharmacy. Thanks so much.
Thank you, Sarah.
Next, identified as John Gray. I'm going to send a request to unmute your microphone.
Hi, good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. Will point out at the outset of my comments that in its 2023 U.S. pharmacy study, J.D. Power ranked Kaiser Permanente as highest in the mail order segment. So I do think we have some interesting perspectives we can probably share with the board on mail order pharmacy services. Specific to some of the issues that the board members discussed, on the topic of inspecting non-resident mail order facilities, I would encourage the board to look at the approach that some other states have taken, where in addition to engaging in inspections themselves, boards may choose to accept recent inspections by either the resident state and or NABP's verified pharmacy program, rather than having to go to the administrative difficulty and expense of sending your own inspectors to all of these states. On the topic of temperature monitoring, we agree with the comments by the California Community Pharmacy Coalition. Hope I got that right, that putting a temperature monitor in every package that requires cold shipping is probably impractical. We would suggest looking at perhaps a policy and procedure based approach. You could look to USP 795 for some language that requires pharmacies to have policies and procedures in place, dictating the manner of packaging and mode of transportation for products that are being shipped, and put the onus on the pharmacy and the pharmacist in charge of the pharmacy to develop policies and procedures that promote shipping product in a manner that will maintain the cold environment that's necessary. And more broadly, I think as you think about how you might want to engage in more oversight of mail order pharmacy, a policy and procedure based approach might be a wise way to do it, where the board identifies important elements of mail order pharmacy practice and then holds those mail order operations accountable to having policies and procedures to meet those specific requirements, rather than dictating to the operation how they ought to.
This is the moderator. I muted the line. The 3 minutes were up.
Thank you, Dr. Gray.
Next individual identified as Stephen Gray. I will set the timer to 3 minutes.
Thank you again. Two comments about mail order. One, the most frequent question I'm asked about mail order is, do the patient-centered prescription labeling requirements apply to non-resident pharmacies? And of course, this means mostly mail order. I don't know if there's an official policy. I don't know whether this needs to be referred to the enforcement committee for discussion, but that's the most frequent question I get. I think it's important that they do, because those labeling requirements went into a lot of surveys talk, and they're very important to our seniors and others. The second comment about mail order is that mail order is just another mode of delivery. whether it's sent by U.S. mail, FedEx, or a 16-year-old with a bicycle and delivers in the local community. It's all about delivery. What we have learned since COVID is that mail order has vastly increased, and with it, a corresponding decrease in prescription consultation. The current law says that if the patient isn't there, consultation isn't required. Even curbside pickup has been determined to be a method of delivery because the patient's representative is not in the pharmacy, and so consultation was proven by a major study in California that proved it had high value to decreasing problems and cost in healthcare and even saving lives. So that's another thing the board needs to think about, is the impact on patient consultation by pharmacists. Thank you for the opportunity to comment.
Thank you, Dr. Gray.
This is the moderator. No additional comments. Would you like me to close the Q&A?
Yes, please. Thank you. And with that, Jesse, your hand did you? No? Okay. All right. Okay, we're moving on to the next agenda item. Agenda item 9, discussion and consideration of the licensing statistics. Members, the meeting materials include a summary of the licensing statistics for the year. The board has issued 2,445 licenses to individuals and 182 site licenses and 96 temporary licenses. Congratulations to all those individuals that received a license during the first quarter, including new graduates of pharmacy schools and those entering pharmacy school. A review of processing time show improvement in several areas. The data report reflects the oldest application of each application type. I highlight that only so that members understand the board's average processing time is shorter than what is reported here. As was projected with staff vacancies being filled and onboarding processing time in several areas is improved. As a committee, we will continue to monitor the progress made by staff. I would like to again publicly commend and thank our licensing staff who have demonstrated great commitment to applicants during this time, many of whom are taking time away from family and friends, working overtime to address these backlogs on the weekends and late nights. Big thank you to our licensing staff. Really appreciate you. And I'm super happy to see our technician processing time is excellent. Thank you all. Members, any thoughts? Any comments? All right.
This is
Public
Jig.
comment.
I
Jig,
just
go ahead.
wanted to thank the licensing team. That's amazing improvement. Thank you.
Thank you. All right, Elizabeth, if you can open the line for public comment.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you're logged in, if you would like to participate, click on the question mark inside of the square, type comments, send it to all panelists. If you called in and would like to participate, press *3 from your phone to raise your virtual hand. Individual identified as Stephen Gray. I'm going to send a request to unmute you.
Thank you again. Final comment for the day. I didn't see in the licensing statistics, and maybe it was there, any report about the number of remote site dispensing pharmacies that had been licensed, or that the few that had been licensed, whether they were still in operation. And I mention that for two reasons. I think it would be important for the board to know how those are going in terms of people taking advantage of the opportunity of the law change, how remote work is monitored, because there's no pharmacist in the remote site dispensing as a methodology for monitoring remote work. In other words, that is pertinent to the discussions we had today. And also it's pertinent to resolving some of the issues about these pharmacy deserts, because that's what it was all about, was to provide an economic and a practical way to open up dispensing sites closer to the patients where they are either living or working, etc. So perhaps I missed it, but if there was anything, maybe someone could comment on it, or maybe in the next licensing committee meeting, we could have some comments on how the remote site dispensing pharmacy idea is or is not working out in California. Thank you.
Thank you, Dr. Gray. I can just point to you to the last page on the licensing committee meeting material attachment has a totality of all the licenses that are currently licensed. And so, yeah, currently it's 0. But thank you for the comments.
Bess, would you like me to close the Q&A?
Yes, please. Thank you so much. All right. Next is future committee meeting dates. With the enactment of the SB 544, which we're going to discuss in November board meeting, all committee meetings are expected to be remote. So these are all committee meeting dates to be projected for the year 2024. I cannot thank you all enough for this lovely discussion. I just knew today's meeting was going to be long. Haven't had this long of a meeting, but thank you all. Lovely discussion. We all don't agree all the time, but it's the beauty of discussing, talking through, and figuring out if there's a way for consensus and trying to push forward on what we think is doing the right thing for California consumers. And I applaud all of you for spending all those times reading all these materials, thinking this through. Thank you so much. And looking forward to our next discussion. And I will see you all soon. And thank you, Renee, for joining again. I'm so glad you're on this committee. We're very happy to have you on this committee. And thank you, Jake. Thank you, Jesse. And thank you, Jason. All of you, thank you so much. And thanks to Anne and all the staff always, and Corinne. I'm sorry, didn't mean to forget it. Thank you. Anne did this amazing work. So thank you all.
Thank you,
Appreciate
Doctor.
it. Thank you. Bye, everyone. See you soon. See you.
Yeah, everyone. Bye-bye.